All right. Thank you guys so much for coming. I know it's finals week, so it might be a little tough to get here, but we still appreciate you all coming out to learn about research today. So today we're going to have a workshop on humanities and medicine. We have a speaker today, a professor that I had in the fall of this year for race and racism, and I immediately loved everything that he was saying. Such an interesting professor. So I'm so happy that we get to have him out here today to talk about his research and the field of humanities in medicine. So without further ado, I'll let him introduce himself. This is Dr. Gravlee, and he'll take the floor.
Thank you, Alicia, and thank you for the invitation to be here. So for starters, I'd like to just get a sense of who I'm talking to. So I know that you all are all interested in undergrad research, but what else? What are your majors? What kinds of futures do you imagine for yourself? I recognize some faces, but not everybody. So let me just hear sort of, since there aren't a lot of you in the room, maybe we can just hear from everybody so I know who I'm talking to.
I'm a philosophy major, but I plan to double major in biology as well, as you would expect from the how this was advertised. I think medicine.
Okay, awesome. You said philosophy?
Yes.
That's how I started. Yeah, love it. Awesome.
I'm an electrical engineer.
Okay.
I was actually biomedical. I'm actually like in a neuroprosthetics lab, so like I'm interested in like kind of also like electrical engineering and medicine.
Very cool. Very cool. This is like a blast from the past for me because my college roommate all 4 years was an electrical engineer as well. So, all right, we're off to a good start.
I'm in biology and health sciences.
Excellent.
And I'm interested in medicine.
Okay, great.
I'm also a health science major.
Okay, all right.
Oh, I'm biochem.
Biochem, awesome. Okay. We'll go to the back here.
I'm a public health major and I'm pre-med.
Excellent, okay.
I'm a psychology major and I'm also pre-med.
All right.
I'm health science and anthropology.
All right.
So very unless.
I'm a microbiome major. I'm thinking of medicine.
Excellent. So I love this, that we've got everything from philosophy to microbiome and a lot of things in between. So as you can see, I'm from the Department of Anthropology. We've only got one anthro major here. How many of you have taken an anthro class? Yeah. Okay, several of you. So one thing that you may have heard along the way is an idea that's often attributed to Eric Wolf, a famous 20th century anthropologist, but it actually predates him to Alfred Kroeber, who was really only in the second generation of anthropologists, at the beginning of the 20th century. And he was famous for saying that anthropology was the most scientific of the humanities and the most humanistic of the sciences. And so the talk is advertised as humanities and medicine, but my perspective as an anthropologist really kind of blurs some of those disciplinary boundaries. And my own training, as I said, I started out college as a philosophy major. I ended up in anthropology. The kind of anthropology that I do really draws on the humanities, the social sciences, and the biological or life sciences. And I also have postdoctoral training in public health. And so that's nothing terribly unusual about me. This is actually something that is true of the way many anthropologists think, because anthropology is the study of humankind, which means that we have to deal with the humanities and the social sciences and the life sciences because we're both biological and cultural creatures. So the focus of my work and what I'm going to talk about today is mainly about social inequalities in health, and especially for those of you who are thinking about careers in medicine, which sounds like most of you. Part of what I want to impart is the crucial importance of the humanities and social sciences, which don't get a lot of attention on the MCAT or on, once you're in med school, on the board exams. But if you fast forward to the day when you are a practicing physician, I submit to you that the humanities and social sciences will be at least as important and maybe more important than how you did on your orgo exam. Because after all, to be a physician, you're interacting with other humans, right? Who live in a context, and you have to understand that context well enough to know what brought them there in the first place, what do they need, how can you negotiate and cooperate so that they get better. And yeah, you need to understand the orgo for sure, But in your actual day-to-day practice, I would argue that the humanities and social sciences may actually be more crucial to your success and your patient's well-being in the long run. So let me just say right off the bat, if I can get this to advance, that my students and I have organized ourselves into what we call the Health Equity and Anthropology Lab, which has the felicitous acronym HEAL. Our approach to all of our work evinces some of what I was talking about the blurring of disciplinary boundaries and drawing on the humanities, the social sciences, the life sciences. We take what we refer to as a critical biocultural approach to health equity. The biocultural is a nod to the idea that we're drawing on the biological sciences as well as sociocultural sciences. And the critical approach is really a nod to some of the humanistic perspectives that we draw on, trying to understand how political economy and questions of power and meaning come into people's experience of health. We also take a community-based participatory research approach. And what that means is that we don't work on communities, we work with communities. We don't just study the communities, we collaborate with the communities. And we try to build partnerships with the people in the communities where we do research so that it's a win-win for everybody. We try to do research that is action-oriented and that has mutual benefit, not just for our researchers, but crucially for the communities themselves. And we draw on a wide range of methods, qualitative and quantitative, collecting people's stories, hanging out, understanding the flow of everyday life, but also quantitative methods, including collaboration with scientists in the life sciences. And I'll tell you a little bit about some of that work. So to give you a flavor of the kinds of things we do, here are some previous dissertations from graduate students in my lab. And you can see a whole range of health conditions and contexts around the world. A heavy focus on stress and culture, as you see in the first couple of cases. One of my former PhD students examined patient and provider cultural models of breast cancer, the sort of negotiation that happens between a patient and a provider. Focus on ethnic health and beauty products among Jamaican women, network analysis of the healthcare structure itself in Nicaragua, and work on food security and food environment in Tallahassee. So this gives you a flavor of the kinds of things my students and I have done. And some of the current projects that we're working on involve the things you see here, really extending some of the focus of my work, which I'm going to tell you more about, regarding the health consequences of racism. Also work on the food environment and community gardens, which really comes out of that community collaboration that I was talking about. And then some sort of methodsy things and additional work on racism and LGBTQ health as well. So what I thought I would do is start with an idea that they don't talk about much in med school. I don't know how much they talk about it in your current majors either, but sort of a starting point for our conversation is to recognize that as a whole, in the United States, people simply are not as healthy overall as we could and we should be. And this was true well before the pandemic. It's certainly evident now, but this has long been the case that the United States invests tremendous sums of money in our healthcare system. You can see here, if we think about the wealth of our country, not only are we a wealthy country, but we contribute a big share of our wealth in the healthcare system. But if you think just about the wealth of the population, of countries around the world, as you might expect, there's a relationship between the wealth of countries as measured here by income per capita and life expectancy at birth. And generally, the wealthier the countries are, the higher the life expectancy. But the United States really sort of destroys this whole trend because we're just not as healthy as you would expect based on how wealthy the country is. And if you think about our expenditures on the healthcare system, it's even more dramatic. So here, we're looking at the amount of money per person in the population that we spend on the healthcare system. And you can see that we're on the far right extreme. We spend a lot more than any other country, and yet we don't get very much for it, right? This has everything to do with the way our healthcare system is structured, and it really directs attention to the need for analysis from the humanities and the social sciences. In addition to this sort of broad view, we have to grapple with the fact that within our population, there are deep, deep inequities in sickness and health that track along, for example, measures of income and racial and ethnic groups. And here you can see the percent of adults who say that they have poor or fair health. And this turns out to be a surprisingly good predictor of mortality, just how people rate their own health at a population level turns out to be a pretty good predictor of mortality. On the left-hand side, you see the relationship with income. As you can see, people who are living below the federal poverty line, depicted on the left, are also much more likely to rate their own health as fair or poor. And we see on the right-hand side, the way that the federal government collects and reports data according to self-identified race and ethnicity. And we see that the proportion of people who rate themselves as having poor or fair health is lowest in this comparison for people who also identify as white and non-Hispanic, higher for those who identify as Hispanic, and higher still for those who identify as Black and non-Hispanic. We also know that if we combine these particular two ways of thinking about social difference, income and race or ethnicity, that income is linked to health across the board. It's a curious fact that the United States is the only country in the world that reports health status by race or ethnicity, but not by any measure of income or social class. We're the only place that does that. And that has a whole history that has to do with the history of structures of white supremacy. It leads people to think that these social patterns actually reflect intrinsic biological differences. So we could do sort of a whole analysis of how those data are reported and the inferences people make about them. It's crucial to understand that across these categories, simply thinking about people's income, their ability to meet their basic material needs in life is a crucial determinant of health. So of course, some of these patterns may be more familiar to you than to any previous generation of students here at UF, because it's been very much in the news in the last 2 years, because COVID-19 has really exposed the way that deep-rooted inequities in our society condition the likelihood of sickness and health, of a long life, or of early death. So that in fact, if we look at that, the first year of the pandemic, we know that the likelihood of death among Indigenous, Black, and Latinx people in the US was at least 2.7 times greater than for those who were white. And of course, this comes at the same time that we have renewed attention to the structures of white supremacy as they manifested in George Floyd's murder, which brought people into the streets in the summer of 2020, just as the pandemic was also raging. And we have to think about the ways that these intersecting crises didn't just happen to coincide, but they actually are also deeply rooted in the same kinds of histories. As manifested perhaps most dramatically in the fact that when George Floyd was murdered, he was also infected with SARS-CoV-2, a sort of individual level manifestation of the way that these large-scale social forces and histories structure the kinds of violence that people experience. Acute violence in the form of police brutality and the sort of what we might call slow violence the chronic wear and tear on people's health and well-being and their possibilities for living long lives. And so when you heard all of the rhetoric in 2020 and so on about the pandemic being unprecedented, about the health crisis that we are witnessing being unprecedented, that's really not quite right. Because actually these patterns are at least 400 years old, where we see that the likelihood of sickness and death, the manifestations of the violence of white supremacy means that really for at least the last 400 years, the likelihood of living a long and full life was constrained especially for Indigenous Americans and for enslaved Africans and their descendants, those from whom settlers took land, and then the descendants of those who were compelled to work the land. And so we see that show up in, for some reason that was not advancing, in our vital statistics as far back as we've been collecting them. So here, for example, you see life expectancy from the period of 1980 to 2006. The good news is, sorry, not life expectancy, but age-adjusted death rates. You see death rates coming down for the population as a whole, but you still see very stark inequalities across the racial and ethnic categories that the federal government uses for collecting these sorts of data. So why? What's going on? Too often in medicine, you will encounter that people have assumptions that race is capturing some intrinsic part of people's biology, some supposedly natural, even genetic differences between racially defined groups. That's the wrong answer. If you go to med school, you're sure to encounter these ideas, and it's up to you to resist them. Instead, another way of thinking about it is to think about the way our society is structured. And an example of that comes from this illustration from the Robert Wood Johnson Foundation and their commission to build a healthier America. Does anybody recognize this map? Don't look too closely at the numbers, but does just the layout of it ring a bell to any of you? How many, yeah? Yeah, it's Washington, D.C. How many of you have been to Washington, D.C.? Okay, most of you. So this is the metro in Washington, D.C., except what RWJF has done is they have looked at the life expectancy of people who live near the endpoints of each of the metro lines in DC. And you can see that in the red line, for example, depending on where you live, life expectancy at birth may vary from 72 years up to 81 years. So it's a 30-mile ride that also relates to a 9-year difference in life expectancy. Similarly, for the orange line, 10 miles from the suburbs to the city, and an 8-year difference in life expectancy. The green line, it's 17 miles and 3 years, and the blue line, it's 12 miles and 9 years. And what this draws our attention to is how the conditions under which people live and work and play and go to school and go to church or synagogue or practice any form of spirituality, how all of those conditions shape the likelihood of living a long life. So most of my work in this area is focused on the puzzle of hypertension in African Americans. And I'd like to tell you a little bit about that. But before I do, let me just hit the pause button and see if, based on what I've said so far, it has sparked any questions or any ideas of your own. Yeah.
Can you elaborate a little bit more on what you were talking about with the non-reporting of income as like a differentiator for health status and how that's rooted in white supremacy? Can you go a little bit deeper into that?
Sure.
Can I interrupt for a second?
Of course.
Do you mind repeating questions so
Great.
the Zoom can hear?
Thank you. Good suggestion. The question was whether I could say a little bit more about the fact that vital statistics in the United States are reported by race and ethnicity, but not by social class, which is unique in the world. If you look at Canada or England or Australia, certainly any other Anglophone country, but this is true of any wealthy country. The vital statistics like, birth rates and death rates and life expectancy and so forth tend to be reported according to some measure of social class. We have no such routine kinds of data collection in the US. What we have instead is routine reporting by race and ethnicity. So think about the way COVID-19 reporting happened. All right, so one problem there was that under the Trump administration, the CDC actively suppressed reporting also by race and ethnicity, so we couldn't disaggregate it, which initially masked the social patterning of death from COVID-19. But the CDC and other branches of the federal government have zero capacity for tracking how health relates to social class. So what happens, let's just take the case of the United Kingdom versus the United States, for example, which is a simple one. In the United Kingdom, the problem is framed in terms of health inequalities, and health status is often measured in relationship to social class. The consequence of that is that it becomes very clear how there is a social gradient in health, and it directs people's attention to sort of a political economic analysis of what are the social structures that shape people's health. In contrast, in the United States, the government frames the problem in terms of health disparities. Some of you may even be health disparities minors. And you even get language from the NIH and the CDC and other federal agencies that refer to health disparities populations. Think for just a moment about what that phrase means. Health disparity populations. What's a health disparity population? Well, okay. So for starters, notice how we've now located the problem in particular populations, not in the social conditions that shape people's health. We're not talking about inequalities, which get us thinking about some arrangement that is unjust or unfair and ought to be remedied. We're talking about disparities, which are mere differences. And when this is combined with the idea of race, the problem is that most Americans assume that what race is something like in our bodies, something intrinsic, something that maybe even is associated with genetic differences. And so when we talk about race and those disparities in that way, what happens is that too often people assume that the disparities are mere differences and that they're natural, they reflect intrinsic genetic differences in people's likelihood of developing certain diseases. That's what led me to this particular puzzle. And so it's a way of framing the problem that obscures the role of social structures. It obscures the role of political and economic forces that constrain people's health and that shapes population inequalities in health. And it leads people to sort of focusing just on individual behaviors and biology as the source of the problem. So it feeds into a bit of victim blaming that also gets the powers that be off the hook. And so, one way that we have seen this show up, for example, is in a lot of the discourse early on, especially about COVID-19, where completely unfounded ideas about supposed genetic differences between racially defined groups were invoked by very powerful people like sitting members of Congress, who suggested that the reason African Americans were dying from higher rates from COVID-19 was because of some unspecified genetic differences. Not a shred of evidence to support that inference, but think about what the political consequences of it are. If the cause of those inequalities is in people's genes, what's the policy implication for that? Like, what do you do? Well, okay, develop some new drugs, maybe? But notice that deflects attention to things like the crucial role of racialized mass incarceration, or the continuing legacy of race-based residential segregation, or of hyper-policing in racially segregated neighborhoods, or of limited access to healthcare, or of the structure of the food environment, all of which are actually shaped by structures of white supremacy. By the way, when I invoke the phrase white supremacy, I'm not just talking about white supremacists like extreme white nationalists and the KKK. I'm talking about what the philosopher Charles Mills describes as the unnamed political system of the global order. It's about the political, economic, and social structures that allocate power and resources. And that's what we're talking about in this context. So when you said go a little bit deeper, I'm not sure if that's, maybe I went too deep. Okay, all right. Yeah, so, and I think this will come out if I maybe talk a little bit about the hypertension stuff. And what I want to say is, given the time, please feel free to stop me at any moment. If I say something that piques your interest and you want to know more about it, or you want to push back, or you have a question, please feel free to say so. So the puzzle of hypertension in African Americans is a puzzle that we've really known about for more than a century now. And the first piece of it is that the prevalence of hypertension or chronic high blood pressure is higher among African Americans than it is among European Americans by a substantial margin, and that this inequality has been estimated to account for 15% of the Black-white disparity in potential life years lost, which means that it is the single most important cause of Black-white differences in life expectancy. It accounts for more of that inequality than any other disease. Cancers, diabetes, stroke, homicide, HIV/AIDS, influenza, all of that. So in terms of public health impact, it's a hugely important problem because of the lives that are lost prematurely because of differences in hypertension. But it's also a really revealing one. This is where we really have to draw on some of the skills and insights of the humanities to analyze the ways that assumptions about race come into the conduct of medical research. And much of the research in this area sort of starts with the assumption that when we measure race, when we talk about race, what we're talking about are some intrinsic biological differences. So you think about, for example, just the titles of some papers over the last couple of decades. So here's a paper in the postgraduate medical journal. It says, is blood pressure different in Black people? Or about 15 years later in the Journal of Human Hypertension, a paper that asks, is the pathogenesis of hypertension different in Black patients? On one level, these titles seem innocuous. At least they were innocuous enough that the journals published them without really a second thought, but recognize that the questions betray an assumption that the bodies of Black people are different, work differently somehow than do other bodies. And so there's this fundamentally essentialist, typological, racist thinking that underlies the very framing of the question. Or sometimes it gets a little more sophisticated, a little more subtle to pick out. Here's an article from the Journal of Hypertension. So just read that title. Is greater tissue activity of creatinine kinase the genetic factor increasing hypertension risk in Black people of sub-Saharan African descent? What do you notice about this title? What assumption does it make?
Hypertension is already increased.
Well, I mean, that turns out to be a fact. We know that there is an elevated pattern. There is an elevated pattern. Yeah.
It's attributing, it's saying that both Black and white people are susceptible to hypertension, but there's a difference in their development. So their bodies are the same, but there's a reason one of them is subject to more of it than the other.
Yes, and it already assumes what that reason is. Is it the genetic factor? So the very framing of the question starts from the assumption that there is a genetic factor that increases hypertension risk among Black people of sub-Saharan African descent. We just have to figure out what is it. We know that that's what it is, but notice the circularity of the logic here, right? We start out with the assumption before we have any evidence to support it, that this difference must be the cause of a genetic factor. So the only question is this particular genetic factor the one, not whether genetics have anything to do with it at all. We've totally, in the framing of this question, totally sort of excluded the possibility that genes actually have nothing to do with it, and that it's purely a consequence of unequal social conditions, right? But that question is excluded by this framing. And here's a place where the humanities are relevant even to the biomedical sciences in a very narrow sense, because it helps us see some of the assumptions that might lead researchers astray and lead them to make illogical or unwarranted inferences. So here's a specific example of that became fodder for research that students and colleagues and I did. This was a study where geneticists at Stanford and University of California, San Francisco, and University of Washington set out to test for associations between individual DNA-based measures of genetic ancestry, which they tellingly refer to as racial admixture. So we already know that they're trying to understand human biology through the lens of race. And the association between individual level measures of genetic ancestry and two biological outcomes: body mass index, BMI, and blood pressure. And they do this in African Americans and Mexican Americans in the Family Blood Pressure Program study. And these researchers conclude that their results were suggestive of genetic differences between Africans and non-Africans that influence blood pressure, but that such effects are likely to be modest compared to environmental ones. Okay, I will give them credit for the second part of the sentence. This part is right. This part is right. This part is not only wrong, but quite harmful. And it's wrong in two ways, the first of which will really blow your mind. It is that if you actually go and read this paper, they actually don't present any evidence of this at all. There is no statistically significant association between African genetic ancestry and blood pressure in their sample, which is why they say it's suggestive, because it actually wasn't statistically significant, but they still suggested anyhow. And the peer reviewers thought that was okay, and the journal editor thought that was okay, and it got published this way. And so it reinforces this idea among physicians and other medical researchers that what we're looking at here is evidence for racist genes. Okay, so that's the first thing. It's like clearly stretching beyond the data. Never should have gotten published just for that alone. But there's a second problem that's a little more subtle and that I think really highlights the need for perspectives from the humanities and the social sciences. And let me just walk you through what I mean. So the way this study was designed, the researchers measured two very clearly biological variables: genetic ancestry based on individual level estimates from collecting people's DNA and comparing to reference populations and coming up with an estimate that says what fraction of people's genome could be traced to putative ancestral populations, usually defined at a continental scale. There's a whole bunch of problematic assumptions built into that I won't go into right now, but let's just take it at face value for now, okay? And then blood pressure, okay, pretty straightforward measure of how your cardiovascular health. And the design of the study was that if they test for an association between these, that then it would be evidence of some genetic mechanism, some susceptibility alleles, that is genetic variants that increase the risk of high blood pressure, that are linked both to blood pressure and that are more common among people of African genetic ancestry. That's their reason. The flaw is that they don't actually measure they don't measure any of these susceptibility alleles. They don't measure any genetic variants that are known to have any functional effect on blood pressure regulation. So it's pure speculation. And can any of you come up with an alternative hypothesis? If it's not susceptibility alleles, what else could explain, if there is an association between these two, which again, remember, they don't actually show, but if there were, what else could be going on? Any ideas? Yeah?
It's mainly environmental factors.
Yeah, it could be environmental factors, it could be experience. How would that work? How would that work?
Well, if you have like race-based segregation, then people are all living in one area. And then if it's an area where there might be pollution or greater risk to health, then it would increase hypertension.
Yeah, so I'll paraphrase and add to that for those who are listening online and maybe couldn't hear because of the microphone. Okay, if you live in a society where people who have higher levels of African genetic ancestry are defined as Black, and where there's also gradations of discrimination, inequality directed people who vary in skin tone, for example, then people who have higher African genetic ancestry may be more likely to live in environments where they are exposed to pollutants or to other toxic aspects of the environment that could affect health, including blood pressure, or could be people who are more likely to be exposed to racialized poverty or to the stress of discrimination in your everyday life. And so all of these things could help explain why these two biological variables may be connected to one another purely because of experience, because of sociocultural processes. So the humanities helps us see the logical flaw, and the social sciences help us then try to measure this stuff so that we can provide better explanations. So I was actually talking about this in one of my graduate classes once, and a former student who's now a professor at the University of California, San Diego, came to my office hours and said, you know that study you were talking about in class? Well, it was publicly funded. It was an NIH funded study, which means that the data were available to download. So she downloaded the data. And she discovered that there was a single variable. There was not a whole lot of robust measures of the experience stuff, but there was a measure of years of education that people obtained. And what she found was that that single variable was a much better explanation for the patterns of blood pressure than was the suggestive evidence about genetic differences. So first she reran the analysis, excluding education. And here's, if you've had stats, you know what this p-value means. It doesn't reach conventional criteria for being a statistically significant association, which is to say it could be due to chance sampling error. But at least we replicated the finding that higher levels of African ancestry appear to be associated with higher blood pressure. But that's true only if you ignore the variable that they had access to in their analysis. Because if you include in the analysis years of education that people attained, then every additional year of education that people attained on average was associated with lower blood pressure of about 0.5 millimeter of mercury, which if you scale that up to a population level, that means the difference between going to college and not, or finishing high school or not, is accounting for a big chunk of this supposedly racial inequality that these researchers were attributing to genes, but really just reflects the racialized distribution of resources and access to public goods like education. And so think about, with these two different analyses, again, to come back to the idea of the policy implications, if they were right in ignoring education and said, what's really going on here are genetic differences between Africans and non-Africans, what's the policy implication of that? Versus the policy implication of saying, actually, we can account for this relationship. It doesn't have anything to do with genes. It's actually a consequence of this one measure of social inequalities in this crucial part of our experience that determines a lot of other things, like the kinds of jobs we can get, the amount of money we can make, the kinds of neighborhoods we live in, the likelihood of good access to healthcare, and so forth. So I find that a pretty compelling example of why paying attention to the humanities and social sciences matters in this work. Okay, so the problem is that now my mind is racing with about 20 years of research that there's no way I can begin to cover it all. So I'm going to pause once more, and I'd like to entertain any questions about what I've said or maybe extensions of it. And then we'll see what to do with the last 13 minutes of our time together. All right, so I'll start here and work around. Yep.
So how does a study like the original one get published with all those considerations neglected?
In a phrase, white supremacy. It's because these assumptions are so pervasive. It's like the air that most, particularly white, but really all Americans, it's like the air that we breathe. That if people observe racial differences in some biological outcome, it just fits the folk wisdom that what race is our biology. And specifically that it's our genetics. It turns out it becomes our biology in the sense that these unequal social structures have biological consequences. But it's just so taken for granted that without the critical thinking skills that the humanities impart, and without really understanding the science of why the concept of race is actually a very poor proxy for actual patterns of human genetic variation, without that understanding, the folk understanding of what race is sort of substitutes, and it leads to the place where the norms of science are suspended. So long as the inferences people are making are about race, the norms of science get suspended. You could never get away with it in almost any other thing. You could never get away with reporting an association like this and saying it was suggestive of whatever effect you thought you were testing. It's only because it sort of fits some prevailing cultural model that has a lot of power behind it that it works. There's another hand somewhere. I thought I saw one more. I did see yours, but I thought I saw at least one other. No? Okay, go ahead.
So do you see the manifestation of these kinds of issues and ways of thought in Gainesville, with it containing a hospital as large as Shands, governing the north central region of Florida? You see these kinds of problems really densely present here?
Yeah, what's interesting is that the reason that I got into this work is that I was a graduate student here, and I was actually, my master's work is about right-wing extremism in Germany. That's the thing I was focused on. But I was dating a medical student at UF who asked me to pretend like I was the attending physician. And she and her roommate were practicing their case presentations. So they started, Mr. Johnson's a 52-year-old Black man who presents with a chronic cough. And I was like, wait just a minute. What exactly does his Blackness have to do with his cough? And she said, I don't know, that's just what they teach us to do. And, as having, gotten an undergrad degree in anthro, I perked up at that and I said, what do you mean that's what they teach you to do? We did away with that idea at least 50 years ago. No, it actually was still circulating alive and well. This was the late 1990s. And it still is an issue, but I gotta say, in the intervening generation, things have gotten so much better. The leadership of the medical school is much more attuned to these issues. They no longer teach medical students that the fourth thing they say about patients when they do case presentations is their race. It still happens for sure, but it's much, much better. And now I'm in the position of every fall, I lecture to the med students about this stuff. So it's sort of come full circle that I got into it because of what I was hearing then medical students saying, and now I get to try to help prevent that among current med students. But I got to say also, one of the reasons things have gotten better here is because of the medical students themselves. They're the ones who keep pushing for lectures like the one I give. They've also really pushed the administration of the med school here to systematically review the curriculum and the lectures that are given to try to purge it of unfounded and frankly racist ideas about race, genes, and disease. And to their credit, the administration, the Associate Dean for Medical Education has been very responsive to those student concerns. And so they're working very hard to make it better. It actually is a moment where like for 20 years, it felt like sort of banging my head against a wall all the time with these kinds of issues. And now we are at a moment in the last couple of years where real change is starting to take place in medicine as a whole, UF Med School included, but but very broadly. Jordan is in a 1 credit hour class that I'm teaching this semester, where we've been talking about the use of race in EGFR equations, which is a measure for estimating the health of people's kidneys. And it's been the case for decades that the way that kidney health is measured has what gets referred to as a race correction factor. Different equations get used. If the doctor perceives that the patient is Black, they use a different equation for estimating how healthy their kidneys are. And the implications of those different equations are that Black patients have to be much sicker to qualify for treatment, to qualify for dialysis, or to be referred to be placed on the transplant list. Their kidneys would actually have to be performing much worse, because it was rooted on this assumption that, like you saw with those titles, that Black people's kidneys work differently somehow, when in fact, the data were simply showing ways that Black people's kidneys were already damaged because of the toxic insults of living in a racist environment. So the good news is that just 6 months ago, the American Society of Nephrology and the National Kidney Foundation came out with a task force report that reviewed all the science and acknowledged that there was no science to support the assumptions, no science to support the use of race correction. And so they've done away with it. And again, this is another story that I hope you find empowering, because the push that really made that policy change happen was that medical students at key places like University of Washington, University of California, San Francisco, then Vanderbilt, Duke, and University of Pennsylvania, all started challenging what they were learning from their professors and saying, where's the science? What's the evidence to support this? And eventually people had to acknowledge that there really wasn't any evidence. And so this is like a really important sort of generational change. Yeah. Okay, other questions? There are many directions I could go, but we're a little short on time. Let me maybe ask you, since you invited me, if there are things that you wanted to hear that I haven't touched on yet that maybe I could briefly elaborate on.
Do you think there's any place for recognizing or like addressing or maybe even acknowledging different races when it comes to medicine, even if you're not placing the basis for differences in health outcomes in their genetics or in their biology?
That's interesting. The only place that it makes any sense is if people are clearly attuned to the way that being racialized affects your life experiences. So in a clinical encounter, for example, perhaps it belongs in the social history part of it, so that we try to understand how race as a system structures people's ability, the range of sort of health promoting choices that are available to them. But as a way of trying to understand people's biology, it has zero place. And I think even including it, I'm certainly not advocating a colorblind approach. What I would say instead is that it should be a race-conscious approach, in the sense that it is conscious of the ways that race structures people's experience, and that we ought to be attuned to some of the forces, in the clinical encounter, but also outside of it, that shape people's health. Yeah, Jordan?
I was going to ask, so how would you recommend that undergraduate students kind of integrate humanities into their current research, or while they're pursuing research, or kind of how to challenge these traditional ideas like in the research setting, especially like if they're in like the College of Medicine or in those kind of like lab groups?
Yeah, there are a number of challenges there, because the pre-health curriculum is pretty highly structured, and so there are certain courses that you have to take to be able to pursue that career. So I would say take advantage of whatever electives you have to be able to take courses in the humanities and the social sciences that are related to health. And that could be in anthropology. There are also courses in our geography department, medical geography, medical sociology, and some of the humanities, history, English, and so forth. So coursework is one. The other is to get involved in research. So in HEAL, in my lab, I think we've only got, of the 6 students who are working with us right now, I think only 1 is an anthro major. We've got a couple of microbiome majors and political science major and so forth. So you can get involved in research beyond just the lab work. And students who have worked with me both in the lab and in my courses have been pretty successful in their health science careers, going to med school, going to schools of public health for an MPH. So yeah, you have to have this sort of pre-health curriculum, but I think one thing that can actually make you stand out is if you also have serious engagement with the humanities and social sciences, and you can articulate in your application how you understand that humans are more than just a constellation of cells, that we live in context and that context matters, and that being a good physician means relating to other human beings. And there are a lot of transferable skills from the humanities and social sciences that could make you a better practitioner. And I think engaging with some of that and articulating some of that is really great. And there are lots of us on campus who do that. In Anthro, I'll just mention 2 of my colleagues by name. Some of perhaps you've had classes with them, but Dr. Marit Ostebo was a nurse before she became an anthropologist. She teaches about health and human rights and global development, and she's a fantastic scholar, does a lot of relevant work in this area. Dr. Adrienne Strong is also a medical anthropologist whose book about maternal child health in Tanzania, she did research on the birth ward in a hospital in Tanzania, has just won an award as the best new book on gender and health in the whole discipline. And she's fantastic. She teaches a course called, let's see, I used to call it like Intro to Med-Anthro, and she very cleverly renamed it something like Everything Your Doctor Told You Is Wrong. Is that, am I right? I'm close to it. Some of you are nodding with recognition. Anyhow, it's a fantastic introduction to how anthropologists approach the study of health and healing. And she's also an accomplished researcher who is eager to work with undergraduates and has mentored many undergraduate researchers as well. And that's just an anthro. There are lots of folks around campus in public health and women, gender, sexuality studies, in sociology and geography. Lots of us who are sort of trying to broaden the focus and thinking about research drawing on the humanities and the social sciences as it pertains to health and healing. So we're, about to part ways for the summer, but if you're going to be back here in the fall, I would invite you to check in with me. We every fall sort of try to bring in a new group of students. So if you have an interest in getting involved in research in our area, then I'm easy enough to find. So I would invite you to come find me, or I'd be happy to try to talk with you about your interest and connect you with a colleague who does work that's more aligned with the kinds of things you want to do, if that's something you're interested in.
Sounds good.
Okay.
We'll give them a round of applause. Thank you so much for speaking today, Dr. Gravlee. Thank you all for coming out. If you guys could hold on for just 1 second, I have a couple QR codes for you to scan. It is just the attendance form if you missed that, and then also a feedback form just so we know how we did. The attendance form, I think I mentioned at the beginning, but we'll send you some notes and updates from this workshop. If you guys liked what you heard today, if humanities and medicine interests you and you want to do research like that, like Dr. Gravlee mentioned, we have a ton of labs at UF. I recommend literally just Googling what you like and then ending that search with UF lab. That's how I found my current research lab. And we, what I'm trying to say is there's a lab out here for you at UF. Jordan and I are ambassadors of CURBS. If you haven't heard of that, that's the Center for Undergraduate Research Board of Students. And we basically just help students find research labs and help them in every step of their research process. So we have peer advising during the day where students can help pair you with a lab and find a lab for you. We have tons of workshops like these. So take a look at our website. It's just UF-CURBS. And then our Instagram is also at UF-CURBS. So take a look at those, see what interests you, reach out to Dr. Gravlee if you'd like as well. He's also teaching a class. Are you still teaching it this fall?
Yeah, it'll be in the fall.
He's teaching race and racism in the fall, class I took, fell in love with. So yeah, with that being said, you guys are free to leave, and thank you guys so much for coming.